So this is a mature intumescent cataract with a high lenticular pressure. So with my 15-degree blade, I make a neck, and then this is followed by injection of the air. And now the anterior capsule is being stained by trypan blue. So with my 2.2 keratome, I'm making my main incision. I go first in the stroma and then bend it and then enter into the anterior chamber. We inject viscoelastic. You can use a high molecular viscoelastic to form the chamber. Now to make the rhexis, I use a cystotome, which is a 26 gauge bent needle. I make a small nick in the center of the pupil, and then I gradually lift the flap, and now I'm guiding the flap in a circular manner. Now while making the rhexis, it's important that the chamber should be absolutely stable. So you keep injecting viscoelastics, and gradually you put your tip of the needle a little away from the point where the rhexis is tearing and guide it in a circular manner. Now these cataracts have a high intralentricular pressure, so it's important to make a smaller rhexis, and as you go along making a spiral rhexis, you end up having a round and an adequate sized rhexis. So now I am debulking the nucleus, making a trench so that I have enough space for the phaco needle to embed. Now once this is done, I embed in the substance of the nucleus, I impale, engage the nucleus, and now I crack it. Now watch as I am cracking. I impale in the center and I place my chopper just close to the rim of the capsulorhexis and move it towards the phaco tip. And as the chopper moves towards the phaco tip, the right hand moves toward right and the left towards left, getting complete chops. Sometimes if you are dealing with the hard mature cataracts, you may have lamellar attachments, so you have to go in the groove and separate those attachments. So you crack the nucleus into multiple fragments, make it small. The smaller you make, the less energy you use to emulsify them. Keep your phaco tip right in the center of the pupil, and with good fallibility, the fragments will get attracted towards the phaco tip. And as soon as the piece occludes the phaco tip, you make it small, you further chop it, and then you emulsify it. If you notice here, the IOP is 55, so with bottle height is pretty low. Considering the fact that we are using active fluidics, the chamber is absolutely stable. Now keep your phaco tip right in the center, and you have to be very careful when you take the last piece. And the moment you emulsify the last fragment, you come back to irrigation and gradually first the chopper moves out followed by the phaco. Now I stabilize the globe with the spatula and make a 15-degree incision. I make another side port diagonally opposite to the first one, and I'm now enlarging the first one because it's a little smaller and we need to do an automated IA. So the IA ports have to go in, the incision should be slightly larger. Now with the aspiration cannula, you go underneath the rim of the capsulorhexis and catch hold of the anterior part of the cortex, get a good grip and move it to the center. Once you have cleaned one side of the cortex, you switch over and now you clean the other side. Go underneath the rim of the capsulorhexis, get a good hold of the cortex, and once you get a nice grip, you move it to the center and aspirate the cortex. It's important that we don't put our aspiration cannula too far, otherwise we may catch the zonules. Now once this is cleaned up, now we are ready to implant the lens. The trailing haptic is placed over the optic and it's inserted inside the cartridge. So now the lens is loaded and ready to be injected. Stabilize the globe with the help of a spatula. And now place the nozzle of the cartridge through the main incision, keeping the chamber stable. Gradually inject the lens. So first the leading haptic comes out and goes into the bag, followed by the optic and then the trailing haptic. You place viscoelastic, form the chamber, slowly guide the leading haptic and the optic in the bag, and then the trailing haptic is placed underneath the rim and inside the bag. We will now remove the viscoelastics above the lens, and it's important to go behind the lens so as to remove the viscoelastics which is there between the lens and the bag. This is very essential, especially in cases of toric lenses or premium lenses, where a slight amount of rotation can change the axis. So do a thorough removal of viscoelastics. The lens is well placed. The rim is covering the peripheral 1 millimeter of the optic. So you hydrate the side port and the main incision. So the lens is well placed, sitting in the bag. Thank you for watching the video.